So welcome, thank you for coming today. This is the first of this year's speaker series for the higher education learning community of Greater Atlanta, RCE, the research seminar series. Our group is faculty from interdisciplinary departments and multiple different universities in the Greater Atlanta area. And we meet and discuss and plan for lots of different things within environmental sustainability. And one of those is this speaker series. We also have some larger events in the spring, including Equinox and Atlanta Global Studies Symposium. Today, we have the pleasure of hearing from Roby Greenwald. Roby is an associate professor and the director of the Master's in Public Health program in the Department of Population Health Sciences in the School of Public Health. He also directs the school's graduate certificate in public health program. His primary research interests are measuring the ways in which air pollution influences human health. Previously, he was in a pediatrics department and an environmental health department, and much of his work involves the development of unique sampling systems for assessing exposure to air pollution in special microenvironments, such as inside vehicles while commuting. Today, he's going to talk about urban built environments, transportation's impact on health and sustainability. Thank you, Roby.
Michael? Okay, so that was a great introduction. It covers a lot of the type of things that I work on and have worked on throughout my career. Today I'm going to talk a little bit in general about how transportation environments in cities especially have impacts on human health. I'm going to talk a lot about how my work that's been done to investigate this really important problem. But I also want to talk about what I think the future needs of the community that investigates sustainability and public health related to transportation are, and what future directions research and policy initiatives should be going in. To get started on this by way of introduction, I just kind of want to talk in sort of broad strokes about what some of the most important health impacts of different types of transportation infrastructure are. So all around the world, in the United States and many other countries around the world, we have large cities with large numbers of people that have to go places. So obviously we have to have some, large scale transportation systems in order for people to move around. It's a basic necessity. But what those systems look like are a matter of policy choices that reflect perhaps cultural attitudes about how we interact with one another. I gave a couple of pictures here of a couple of examples of different types of policy choices that may be useful for moving people around. Some of these may be more useful than others. I'd like to point out here that there's these two different pictures here, one from Amsterdam and one from our lovely city of Atlanta. In the left picture here, we see a two-car tram pulling up to a station, and that tram holds 350 people. Well, it could hold. Who knows how many are on there right now. This picture over here on the right, I meticulously counted up every single one of those vehicles, and there are 323 vehicles in that shot. At the average vehicle occupancy rate, that is about 410 people. So in other words, two of those tram cars has already surpassed the number of people stuck in that traffic jam in Midtown Atlanta. Say what you will about that, but that reflects a policy choice that has a downstream effect on the health of the populations living in these cities. I'm going to describe some of the other major important public health impacts related to transportation systems, and then I'll get into describing how I specifically have been measuring some of these things over the years. This is a little bit blurry. I hope it shows up a little bit better online than it does in here, but right now. But what I'm showing here is the most recent data we have from the CDC's Whiskers website, or the data visualization program. It's from 2022, and it's showing the major causes of death in the United States that are stratified by age. And they're kind of color coded by what type of what the major category of causes of death are. So the green and the red here is violence, either violence to yourself or violence to others. homicide, suicide. The blue is unintentional injuries. So if you kind of look across the age range, you see the infants, people less than 1 year old. Well, fetal development is a risky procedure. Birth is a risky procedure. If you get past those hurdles, get past infancy, you've gotten past a lot of these causes of death that really only show up at infancy. And then you go over to the other end, you see the end of life diseases, heart disease, cancer, start catching up with you, and you start seeing large numbers of people dying of cancer, heart disease, things like this. But in the middle, in between that risky act of being born and the risky act of getting old, in between, what ends up killing most people or have the largest causes of death are these unintentional injuries, or in some cases, intentional injuries. In a perfect world, we'd make those green and red boxes completely go away. We would try to make those blue boxes as small as possible. If we kind of dive in a little bit deeper, see what causes are in those blue boxes. What are the causes of fatal injuries in the U.S.? The chart over here on the right-hand side of the screen kind of breaks that down. Going across the age range, you see that the light blue box there is motor vehicle traffic. Motor vehicle traffic for up until early adult years is one of the major causes of these unintentional injuries in several of these age categories. It is the major cause. It is the leading cause of death in the United States. If you kind of look at how this has changed over time, this chart here tracks some of these same causes of death back all the way to 2005. I have been teaching on this subject long enough that when I first started teaching, the black line on this chart was higher than the red line. But what's happened is that the red line really is reflecting the opioid epidemic, and the unintentional poisonings has now become a major public health crisis in its own right. The black line here is showing fatal injuries due to motor vehicle or pedestrians in some cases who are struck by motor vehicles. And that the trend in here is worth pointing out and worth discussing a little bit. So, before this chart starts, all the way back to the 1960s, the motor vehicle fatal injury rate in the United States has been coming down very consistently. It is not just true in the United States; it's been true in many countries around the world. When you get up to the mid 2000s, we kind of hit a valley. It just kind of stops and it doesn't continue to go down. When you get to the mid 2000 teens, the death rate actually starts to go up again. This recent increase is somewhat unique to the United States. Not absolutely unique, but most of our other peer nations do not observe the same trend. They continue to observe decreasing death rates from motor vehicles. Some of the other colors on here are just like that purple line showing deaths from unintentional falls. That just reflects aging of the population. You're more likely to die if you're old and you fall down than you are if you're young, and as the population ages. Let me show you another chart that kind of dives into those motor vehicle crashes in a little bit more detail. And we're switching a data source here. We're going from a CDC data source to a U.S. Department of Transportation data source. The numbers can be a little bit different from each other by the way that they accumulate their data. But on the right-hand side here, we're looking at the same kind of time series. The red line on the top of this is showing the deaths from people who are inside of a vehicle, either the driver or passenger. And it doesn't necessarily show that you're at fault or the cause of the crash. You a different vehicle. The lines down towards the bottom, the ones that have much smaller numbers associated with them, are motorcyclists in blue, the bicyclists are in purple, and black are pedestrians. So what's kind of hard to tell from the scale here is that the bicyclist deaths are creeping up slowly. The black line showing pedestrian death, that's creeping up a little bit more apparent when looking at this slide here. And then the dotted line that's on the right-hand scale here, that is showing the number of fatalities per 100 million vehicle miles traveled. We'll come back and talk about this in just a second. The federal and state departments of transportation really like to express their data in this way because it makes them look better than expressing it in other ways. But from a public health perspective, it's a somewhat misleading statistic, and I'll explain why in just a second. So in the most recent year that we have full data, 2022, in the United States, there were over 42,000 people killed by traumatic injury related to motor vehicle. If you divide that out by the number, all the total distance in the entire country of all the cars and all the trucks driving on public roadways, and then use that as your denominator, this comes out to 1.33 deaths per 100 million miles of vehicle miles traveled. And like I said a second ago, this statistic is a little bit misleading from a public health standpoint. And the reason why, and let me explain here to make it a little bit more clear. If you woke up this morning and for a second you contemplated your own mortality and thought you might likely to die today or not, if your neighbor drove 100 miles instead of 50 miles, did it change your perception of your risk of death? Because it lowered that number, it made that number smaller. It may or may not, it made that number smaller, but it doesn't actually change what your risk of death was in a positive way. If anything, it slightly increased your risk of death. A better way to express that is that it's the fraction of the population that is at risk of death. That's a more traditional way to express public health risk. That number in the United States comes out to 12.8 deaths per 100,000 people in the US per year. As a point of comparison, let me show just some of the similar statistics for the nation of France. Now, I picked France not because it's special in any way. It's just a peer nation that has a population that's smaller than the United States, but it's not tiny. They have very similar technological capabilities. They have similar, the roadway infrastructure has many similarities to the U.S.'s roadway infrastructure. The total number of people in France that died was a little over 3,000. If you do the calculation of the number of deaths per miles traveled, it's almost the same as in the United States. So in other words, if you're on the roadway in France, driving somewhere, that then per unit miles traveled, the risk is about the same. But if you look at the fraction of the population that's at risk, the risk is less than half in the United States. Now, France is sort of the middle of the road when it comes to peer nations. When we look at like the best of the peer nations in roadway safety, they're much smaller than France even. So the United States is really an outlier on this issue when we look global. Now, I'm going to make another comparison here. So bear with me here. The statistics aren't exactly the same and aren't exactly comparable. But if you decide to yourself, well, you know what, roadways seem a little bit unsafe, I want to do something else. What else would you do? Well, perhaps you take MARTA in the city of Atlanta. So in the year 2022, there were a grand total of 3 fatalities on the MARTA system. One of those was a suicide. 2 of those were homicides. I looked into the incident reports for all of those incidents, and the way the incident reports are described, it would be somewhat analogous on a roadway to road rage. In other words, 2 people are fighting with each other, and they just happen to be fighting on MARTA property. In no case, in fact, going back many years, in no case was there an incident where just an average random person riding MARTA was the victim of a homicide on the MARTA network. But anyway, if you take those 3 fatalities that occurred in 2022 and you do the same style of statistics, that comes out to 4.8 deaths per 100 million miles traveled, which might seem like it's bigger than the roadway, but that's because the denominator is a lot smaller. But if you look at the number of people who use MARTA on a daily basis, this comes out to 3 deaths per 100,000 users, which is quite a bit smaller than even our comparison group of France, and it's like a fraction of 1/4 lower than what the roadway risk of death is. So I'm just pointing that out that these comparisons show that the roadways in the United States are unacceptably high risk of fatalities. I describe, when I talk to students in some of the classes I teach, I often share this slide with them. And when students look at this, a lot of the reaction I get many times is, what's wrong with you? It's like, are you some kind of agent of chaos? Like all these people you've known in your life have been killed in roadway violence? And I'm like, well, I hope not. But what it really probably comes down to is that I'm Generation X. And when I was born, most cars didn't have seatbelts, and airbags hadn't even been invented yet. So during my childhood, it was much more common than our childhood today, probably, to know people who have been injured or killed in roadway crashes. But it's a very long list And this has radicalized me in a certain way to want to confront this issue, throughout my career. Now, it's not just, all of these charts so far have just been talking about traumatic injuries and the impact of transportation systems through injury, but there's lots of other impacts of transportation systems on public health. One of the ones I'm going to talk in much more detail about are air pollution emissions. In the United States, the transportation system is the major source of air pollution emissions that have health impacts. Over the last decade, the number has been coming down. The number of deaths that are attributable to exposure to air pollution from roadways has gone down by half. That's very good news. This is the result of a lot of engineering innovations to improve filtration of particle emissions from engines. There's no way to say this is really good news. We've done a really good job tackling this, but these numbers are still high compared to many of our peer nations simply because we have many more vehicles. If we switch over and start talking about describing air pollution emissions in terms of their impact on chronic disease, talk about their impact on climate, then the transportation system in the US is the single largest source of carbon emissions. These numbers have been fairly flat. The green line on this chart from the EPA is the transportation emissions. This line has been more or less flat over the last decade, with the exception of the COVID years, and many of the other sectors of the economy that have the emissions have been coming down. And I think it's worth describing for a second why we see some of these differences in these trends. So in the US, the fuel economy of vehicles is regulated using what we call CAFE standards, or the corporate average fuel economy standard. That standard has been increasing with time. But the standard is a little bit different for cars and light trucks, and I think something really important to point out is that an SUV is classified as a light truck, and so the standard is different for an SUV than it would be for a passenger car. So even though both of those standards have been going up, if the fraction of the cars sold are SUVs instead of a sedan, then what you actually see is a reduction in the fuel economy rate. And something else that is really important to point out about this is that this does not have anything to do with how far you drive those vehicles. So if you get 30 miles to a gallon instead of 29 miles to the gallon, but then you drive twice as far, you're actually emitting more than you would at a lower fuel economy. So you put those two things together, we are seeing emissions hold steady or slightly increase depending on economic conditions in any given year. In addition to these things, I just kind of I feel like you can't really discuss this subject without mentioning some of these other factors here. We're not really going to go and talk about them in any more detail, but a transportation system that's single-mindedly focused on motor vehicles as how we move people around has many other negative downsides as well to public health. I'll just kind of list many of them here. They're loud. They're the dominant source of noise in most cities. They reduce physical activity rates. The reduced physical activity rate of the person driving seems kind of obvious. If you're driving, so walking somewhere, you're not being physically active, but they also reduce physical activity rates for people who are around the other cars. And so you'd be less likely just to walk down the street to the store if there's a whole bunch of cars around you. They're very expensive. They're the most expensive way on an individual basis, the most expensive way for a person to get around. The average cost, when you include maintenance, fuel, insurance, all those things, it's $1,000 per month in the United States. The infrastructure we built to accommodate massive numbers of vehicles divides communities and ends up being like barriers that make it hard to make it mobility much more difficult. The list is a very long list, and this is not the focus of this talk, but I felt like we can't really describe the public health impacts of transportation without at least mentioning many of these other factors. So now I want to describe a little bit of how I got into focusing on this as part of my career pathway, kind kind of explain, some of the steps I took to get to where I am now. So when I first started my career as a scientist, it was what interests me, what I envisioned myself doing for the rest of my career was climate science. So I went to Georgia Tech for my PhD, worked in the environmental engineering program, and did a couple of other projects, but most of them were related to how particulate matter, mostly coming from anthropogenic emissions, how that was impacting how plants grow, specifically how much food you can grow from those plants, and then also how that would affect the formation and lifetime of clouds in the atmosphere. So to do this, part of these projects, I developed a new style of instrumentation that can measure particles in the air that are not soluble in water, measure how big they are, how many of them there are, do this with very fine time resolution. Took them to many places all around the world trying to investigate what some of these impacts are. Took them to, here's some pictures of taking them to the Greenland ice sheet, kind of see how far can emissions from cities be transported through the atmosphere and impact very remote environments, and how this, what types of influences this has on the stability of the Greenland ice sheet. And we found that even in very remote places, we were finding the soot particles as ultimate source for transportation systems in cities that were hundreds of thousands of miles away. When I switched over to my postdoc at Emory University School of Medicine, I started looking at how some of these same types of particles, these same types of emissions were influencing human health rather than specifically climate, and that altered the trajectory of my career from that point on. So started working on a couple of really important studies that have, I'm proud to say, really had contributed to the scientific understanding of how air pollution is impacting human health. So one of the early studies, this is a really long study that lasted for many, many years, but it was a quite large, quite difficult study to just the logistics of collecting all of this data. But we ran a study where the participants would drive their own vehicle. So they had to have a vehicle. That was a little bit of a selection bias. They had to have a vehicle. They drove their own vehicle for 2 hours and somewhere around Atlanta, and those 2 hours were 7 to 9 a.m. And one of our study staff would sit in the vehicle with them and help them kind of keep all the instrumentation working right, and also be telling them where to go. Very it was odd to many of the study participants that the staff member would see a traffic jam and tell them to get into it on purpose, and they would seek out the worst traffic they could find. And do this for 2 hours. We measure all kinds of the air pollution, many different aspects of the air pollution, but we also measured a lot of different health outcomes related to health outcomes that would impact many different physiological systems. We did a lot of things related to airway oxidative stress. We also did things related to cardiovascular health, including heart rate variability. The fact that participants drove their own vehicles meant that we got lots of different types of cars in the study, and many of these cars had very, very different types of air pollution that was infiltrating the vehicle cabin. We did protocols like rolling your windows up, rolling your windows down, seeing what kind of differences there are, how the vehicle's air filtration system was, whether it was or was not efficient at removing particles. Most of the time it was not, just FYI. For many of the pollutants, if you roll the windows down, you don't see much of a change at all. The way I would describe it is like the really big particles, you see a change, but the really, really small particles, you don't see much of a change. From a health standpoint, it's the really, really small ones that you should be concerned with. So the fact that the big ones don't get in is not the health win you might have first seen. We found, as we're driving around the road network, usually we spend a lot of time on I-285 on the north side. If you're near a whole bunch of big trucks, well, guess what? The air pollution inside your car is a lot worse. By coincidence, this particular participant was in the study before this story broke, and then after the fact, we realized it. But The participant had a Volkswagen Jetta that was one of the cars that Volkswagen cheated the emissions test on. And it's the interior of this car had black carbon values that were just off the charts. Now, if you're not an air pollution scientist, you might look at these numbers over here and not know what they mean. But if you're exposed to 50 micrograms per meter cube of soot, that is out of this world. If that was outdoors, you would be alarmed. Like, I mean, the dirtiest city in the world does not have that much black carbon in it. In fact, if it's above 2 somewhere out in the city right now, we're like, wow, we're raising our eyebrows. Some of the health effects that we found is that your heart rate variability is suppressed after you're exposed to the type of air pollution you get on roadways. Heart rate variability. You want your heart rate to be very variable. That shows that you're physiologically respond to changes in stress levels and physical activity and things like that. So when it's depressed, that's actually a bad thing. We did see differences between people who had asthma and people who did not have asthma in this trend. We looked at different markers of oxidative stress occurring in your airways, lots of different ways of evaluating this, and we saw that when you're exposed to these types of air pollutants, your oxidative stress goes up. Again, we saw big differences between people with asthma and people without asthma. If you have asthma, you're more susceptible to these effects. And then we also recruited people, or we had our asthmatic participants do an asthma control questionnaire to see how well controlled is your asthma. And amongst the asthmatic group, the more severe your asthma is, the more pronounced this effect is. Now, I should point out when I'm showing all these slides here, the participants themselves could not tell. Like they did not report symptoms being worse. These are biomarkers that are below a clinically perceptible level. We also found that your antioxidants are all getting consumed. So in other words, if you're exposed to another oxidant and you don't have antioxidant capacity, it's much more likely to have a negative impact. I spent a lot of time on this study trying to look at different ways of characterizing what your exposure to air pollution is and trying to see which one best captures the association with the health response. So one way you can think about it is that, well, if you're inside this car for 2 hours and we're measuring air pollution the entire time, the average amount of air pollution in there, is that associated with some of these health outcomes? Your heart rate variability being suppressed, your oxidative stress increasing. We could also, since we are collecting time series of these, and we see it changing very rapidly at very different points in time. What if we look at like those peaks? Or you have like a 5-minute long exposure somewhere in those 2 hours. It's really, really high, much higher than the rest of the time. Is that more predictive of what the health response is? And it turns out that it is. And the hypothesis for why that is more predictive is that you are, in that very short period of time, you're consuming your antioxidant capacity, and that leaves you. For the subsequent exposure, which may be at a lower level, you have less chance to respond to those oxidants, so you see more oxidative injury. This study was one of the first studies. It's become quite common in air pollution or transportation-related air pollution studies since then, but it was one of the first studies to really show that your exposure to the brake pads and tires of all the vehicles around you is actually just as important as your exposure to the emissions from those engines. So kind of think back to a few minutes ago when I said, well, we've gotten really good at reducing engine emissions. Engine emissions and your brake pad emissions are totally separate categories here. Like how many particles are coming off of your tires and how many particles are coming off of your brake pads is really a function of how big your vehicle is, how fast you're stopping, how fast you're driving. And so even with very, very efficient engines, but really, really large vehicles, you're increasing the emission rates of some of these things. And this also has a significant association with the health outcomes. So after we're actually concurrent with this study, so we're working on another study where I was looking at exposure to air pollution at the same time that you're engaged in physical activity. So, one of the things we're really concerned about in urban transportation systems is that it's having this negative impact on physical activity. But when people are physically active, they are around some of these sources. And so now your exposure to the harmful emissions from these sources is actually higher. And of course, anybody who's ever walked up a flight of stairs, immediately your breathing rate goes up. When you do that, the amount of air that you're inhaling per minute goes up, and if there are harmful pollutants in that air, your dose has increases. So this study worked with a lot of mainly with adolescents who are active in their school's extracurricular activities. I show a picture of a football player here, but it's many different sports, not just football. In fact, we also included the band. And in a couple of the schools where we conducted this study, the members of the marching band actually had higher average physical activity rates than members of the football team, because the football guys sit around an awful lot. So we're measuring some of the similar things that we're doing in the commuters study. We're measuring similar types of health endpoints. But one of the things that I'll introduce here, so I'll talk about it again in a few minutes, is that we also were collecting saliva samples from many of these participants at various time points during the exposure. And from those saliva, we were working with the Emory School of Medicine to do salivary metabolomics, which is essentially what we're talking about here is that we're measuring all kinds of thousands and thousands, very high resolution mass spectrometry. You're measuring thousands and thousands of different metabolites that are present in many different biological media, saliva in this case. In many cases, or most cases, we actually don't know what those metabolites are. We don't have a positive identification of it, but some of them we know what they are, and some of them we don't, but we see them tracked together, and we can kind of see which metabolic pathways are being activated and which of them are being deactivated, and we can get some type of clue about what the response to that exposure is. A very important part of this study is in retrospect, this ends up being the most cited part of the study is the methodology for characterizing what that dose is. So I put a couple of examples here going across the top of this chart here. This is real data that we collected from a couple of different groups and in a couple of different ways of characterizing the exposure. So on the left, the chart here on the left is just looking at the concentration of a pollutant, in this case, PM 2.5, it doesn't matter, smaller than 2.5 microns. So just looking at the concentration these two different groups are exposed to. If you look at just that chart on the left, you go, oh, well, the people in group 2 are exposed to more, right? I mean, their numbers are higher, they're exposed to more. Okay, well, let's go to the middle group, the middle chart here. It's the same group, the same data. One of those people, or one of those groups could, on average, be there for a longer period of time than the other group. So one could be there for an hour and 20 minutes, and another group could be there for 1 hour. So you would think, okay, well, your exposure is higher, concentration times time is higher. So if you look at that middle one, you're like, oh, okay, they're more the same. And then if you go over here to the far right chart here, well, the group 1 was sedentary, they're just sitting there. And group 2 was being highly physically active, so their breathing rate was a lot higher. So you look at the inhaled dose, amount of PM 2.5 that these participants actually inhaled into their lungs, then group 2 is the one that has the low exposure, and group 1 is the one that has the very high exposure. So this methodology for calculating dose was a really crucial part of the study. What we found is that how you assign the exposure, which metric you use to calculate the exposure, is crucial for understanding what the impact is on the health outcomes we measured here. So without diving too deeply into how to interpret this chart, the take-home message from it is, as you move to a more physiologically relevant way of assessing the exposure, your ability to, the association with some important health endpoint gets stronger and more clear. We collected the saliva to do metabolomics here. This is kind of showing the thousands and thousands of different metabolites, and we're looking at the relation, like the change in intensity of these different metabolite features in the saliva samples between different time points. And we're seeing which ones have a really, a very a very small p-value associated with that change. That's an imperfect way of assessing whether or not it's like a real physiological reaction to something, but it's a good first step to trying to see which types of pathways are being initiated and which ones aren't. We used a pathway analysis tool that's called HELC. That's named after a fish. I did not know that until I've been using this tool for a couple of years, but the HELC bioinformatics platform takes this data that we just kind of looked at in visual form just now, and identifies different types of metabolic pathways that may be changing either in a positive or a negative direction between your two different end time points. And when we do all of that, we came up with some really confusing data. Metabolomics data is very, very difficult to interpret, and I'm still learning something every time I dive into it. But one thing that we were finding is that there are important metabolic pathways that are associated with inflammation and oxidative stress that are activated by different exposure metrics. And when you use those more physiologically relevant metrics like your dose per kilogram of body mass, you see stronger associations. The next work related to this transportation exposure I want to talk about is a study called Trees Reducing Environmental Exposures. Here we gotta have acronyms that mean something. So TREE is the name of the study here, and we're looking at roadside barriers along highways, specifically in Georgia, in Atlanta. So Atlanta is definitely no exception to a nationwide trend that many cities in the U.S. have these massive roadways going right through the middle of the city. The downtown connector around Midtown has 17 lanes across from one side to the other, and at many times a day, all 17 lanes are full and stops and idling and just releasing all kinds of emissions in the air in those areas. So if you want to think about, well, how do we reduce the exposure of the population to these emissions, there's a lot of different strategies you might pick. One of them would be, well, if we just drove less, then maybe we would have less emissions associated with this. If we made the vehicles emit less for the amount you drive, that would do the same thing as well. But if you can't do any of those, or if you have, those things are really difficult to do. So what if we just, prevented those pollutants from dispersing to adjacent populations? Will that be a strategy for helping reduce exposure? So that's what we were testing in this study. So if you drive around the roadway network in Atlanta, you've probably seen barriers in many different cases, many different places that are constructed in slightly different ways. But they're pretty common around most of the major roadways in Atlanta and lots of other cities. A barrier such as this one pictured here is just a solid sheet metal barrier. Its purpose, like the reason why Georgia Department of Transportation spends money on this, is not really air pollution so much as it's noise. And that's noise from escaping to adjacent neighborhoods. But it does also change airflow and dispersion of air pollutants. If you have a bunch of trees planted along the roadway, a bunch of vegetation, this also does a good job at preventing dispersion of pollutants. Now, the thing about that's really noteworthy about trees is that they are evolved to have as much surface area as possible on their leaves poking out here, so they grab as much sunlight as they possibly can. Well, that surface area is also pretty good at collecting particles. Like if a really small particle bumps into a surface, they tend to stick, especially when you get down to the nanoscale. They tend to stick. So if you have a high surface area, you're going to pull more particles out of the air than if you have a low surface area. So a tree does it better. They're not so good at preventing noise. They're not as good at preventing noise from moving through, but they are pretty good at preventing particles from moving through. Now, in a place like the southeast United States, where it's warm, sunny, and rains a lot, you have anything outside, it's going to get covered in vegetation pretty quickly, unless you're actively out there chopping it all down. So a lot of the roadside barriers around Atlanta actually kind of look like this. They're both solid and vegetated at the same time. This is not intentional here. This is super fast growing kudzu climbing up the side of this barrier, but lots of places also have like trees in the right of way in between the barrier and the roadway, so you have both trees and solid barrier. We used Google Street View to scout out some sample sites with the the issue that Street View may be a year or two old, or more in some cases. So we would have to like do actual physical driving around to find our sample sites. Where's a good example of all these different categories? We came up with 5 different sites that represent some combination of these categories around the metro area. All of it is either on 285 or inside of the perimeter of 285. We started this study in 2019, and then 2020 happened, and so our sampling in 2020 was very, very different than our sampling in 2019. Which actually turned out to be a good thing for the scientific purposes of this study. It turned out to be a good thing. We got to see how sensitive is this to the volume of vehicles on the roadway, which was unnaturally low in 2020 compared to 2019. We made many of the same different types of measurements of air pollution. Now, one thing about this study that's different than many of the other ones I've talked about, there are no human subjects on this study, so we're not doing any health endpoints of a population that's exposed to. What we did find for this is that the type of barrier you have really does matter. Also, this is very obvious, but the wind direction matters. If the wind is blowing from the highway through the barrier, it's going to remove particles, but if it's blowing the other way, it's not. So wind direction really does matter, and you don't control that. So just have barriers all around. It's the take-home message from that. We also found that the barriers are better at removing some kinds of particles than others. So the really large particles, the things that the EPA regulates, PM2.5, is big compared to things like soot particles and really small ultrafine particles. So the big things that are regulated, well, they have a different relationship than the really, really small things that we might be more concerned with from a health standpoint. Another study that was concurrent with that last one, this one is not quite, it is still ongoing in a way. We finished sample collection just about 3 weeks ago. So the last samples have been brought in, but we're still analyzing the data and analyzing our biological samples. So this study is looking at children in particular. Now, we've known from epidemiology, we've known for a really long time that the health effects from air pollution exposure happen very, very early. In fact, they happen before you're even born. Your mother's exposure to air pollution impacts your health response. So we do lots of studies with adults. We do even some studies with adolescents. You know, you can work better with a subject who can talk to you easier than you can with a 3-year-old who really can't follow instructions or talk back to you. So it's, you know, there are challenges with working with younger populations. For example, you can't really definitively diagnose asthma before a child is old enough to be able to follow the instructions and do complicated breathing tests. So you may suspect a child has asthma at the age of 3, but without being able to do the full pulmonary function test, it's really difficult to diagnose that definitively. But there are other health outcomes that you can measure in 3-year-olds that are able to tell us something about what the biological response is. So for this study, we're using a similar approach we used with the adolescent athletes. We're collecting saliva samples from the children. It is pretty easy to collect a saliva sample from a 3-year-old, and it's non-invasive. And in fact, we got our approach down to the point where the 3-year-olds actually liked it, made a little game out of it. And so this is the best way to work with a healthy population of very young children and get a scientifically relevant health endpoint that can tell us something about what's happening. So we were going to childcare centers around Atlanta, and I always, whenever I'm talking to the operators of the childcare centers, I always emphasize, I'll emphasize to you as well. We don't go to these childcare centers because we're scared of the child, because we think they're dirty. We think they're a bad place for kids to be. The air is especially bad. Not at all. It just reflects what the city of Atlanta's like. We go to the childcare centers, that's where the kids are. And you know, most children in the United States spend 8 hours or more in a childcare center during the ages of 3 and 4 years. So it reflects what children are exposed to in many places. We picked a couple of different childcare centers within the central part of Atlanta. I'll show you a map in just a second. One of the things that we agreed is that we would never say their names out loud, but we are showing where they are on a map, so you kind of see what part of town, different parts of town they're in. We measured many of the same types of things that I mentioned so far in a lot of the other studies. We're measuring gas-based pollutants and particulate pollutants, we're measuring soot. But one thing that as kind of get closer in time to the present, the technology is improving. So now we have really small sensors that even small children can carry around with them and do a pretty good job, not great, but not perfect, but a pretty good job of measuring what the air quality is like. So we use a lot of these micro sensors for measuring air quality, both at the child care centers and at home and in the car, in between the child care center and home and wherever the children go. So we have a number of different ones. There's different brands, have different pros and cons, but they all use a pretty similar methodology for measuring. They use the interaction of particles with light. It's an optical method. We also specifically used a small and lightweight instrument for measuring exposure to soot, since that we already know soot has a very pronounced health impact. So our sample size, I'm only showing 2 here because numbers 2 and 3 are really close to each other, and you can't show both 2 and 3 on a map of the scale. 2 and 3 are pretty close to each other in downtown Atlanta. Site number 1 is to the east of downtown Atlanta. It's 4 miles from here. And what's notable about site number 1 is that you're not right next to a highway. You're about a mile away from a highway. So the air quality is kind of reflecting what the city of Atlanta's air quality is. Site number 2, on the other hand, is right next to a highway. So you have all the air quality issues that the whole city has, but also you have emissions right there, just you're immediately adjacent to where the child care center is. Something else about site number 2 is it's also right next to a rail line that is actively used. There are diesel locomotives going by several times a day. In some cases, those locomotives stop at this point and idle while another train's going by. So those are emissions right next to where the child care center is. There's also a parking deck right next by, so you have idling cars in and out of this parking deck, and the outflow from that deck impacts the site as well. For this study, we had to, since we're using all these relatively new micro sensors that may or may not have been evaluated rigorously in the past. The first step we had to do is do that, rigorously evaluate them. We came up with a good method for correcting them to something that would be comparable between different sites and different types of instrumentation. Just to give you a little snapshot, like I said a second ago, we just finished collecting data a matter of weeks ago. But we've been doing this for a couple of years, so we have data going back to 2 winters ago. But one of the sites we saw indoor black carbon levels could be extremely high on especially cold nights when a furnace was kicking on. The thing that's you have to point out about this, though, is it always happened in the middle of the night and no children are present, so it's not really reflecting what children are exposed to. But it is an illustration of a furnace that's not in tip-top shape, that's burning a heavy fuel, can produce a lot of pollutants in the indoor space. This is from the site that's near the roadway. We saw that the indoor concentration of soot at the site near the roadway is higher than the outdoor concentration of the one that's far away from the highway. It just kind of reflects the infiltration of the outdoor air pollution into the indoor space. Sometimes we would see the indoor black carbon just be super high for no real explicable reason, and installed a webcam on our instrumentation. At first, we didn't have a webcam on it, but then we were like, oh, we need a camera over here, and put a camera on there. And yep, sure enough, when you see these big spikes, there would be a locomotive going by. Just a matter yards away from where the instrumentation was. The children also, or I should really say the parents of the children, took home the microsensors with them. We had a little backpack that they could carry. And they would, we're importantly looking at what transportation's like in between, and also what your at-home environment was like. And these families are living all over the city. In some cases, the child care center is close to where the parent works. They could be anywhere. And in other cases, the child care center is close to where they live. So the residential exposure is very similar to the child care center. In this particular example, this is just a representative sample here. Is that we would sometimes see really high indoor levels at the person's home. And this is associated with meal preparation. When you're frying a lot of foods, for example, lots of oil droplets in the 2.5 micron range get into the air, and you can see the PM2.5 values go up. And I always emphasize that because you see these numbers get big doesn't necessarily mean something toxic. You're exposed to something toxic. These are not the same type of particles that the outdoor ambient particles that have more, from a toxicity standpoint, have more concern for us. In this study, we also saw during that transportation back and forth from home to child care center, sometimes that would be where all the highest exposures were. But the study has, I should say 2024, August 2024, we finished sample collection. And as we speak, these saliva samples are being analyzed by Dean Jones at the Emory School of Medicine. Okay, so I'm almost up to the present. So the study that another study that we are still working on right now in Atlanta is a study looking at the infrastructure in different neighborhoods around South Atlanta and how that impacts residents' perceptions, how safe the transportation system is, how they behave. Do you walk places more in this neighborhood than that neighborhood? Which mode of transportation do you use? Physical activity in general, how not just physical activity for transportation, but just all physical activity, how do those rates differ? And also, how do the air pollution exposure differ across neighborhoods? Now, this study included lots of different moving parts. Some of it are, the biggest parts here are doing neighborhood surveys through some of these neighborhoods. We chose a matched pair study design here. So we would have two neighborhoods that are near each other and are very similar in terms of demographics, in income, age, factors like that. But one of those neighborhoods has been designated by the city of Atlanta to receive a complete streets project within the next couple of years. And one of the neighborhood next door isn't receiving a complete streets project from ATL DOT. So the concept here is that we will do this again after construction has occurred of changes to the infrastructure. We also have used a truck outfitted with a LiDAR setup in the back of it to drive around and kind of get a glimpse of what the street architecture is like, where the curb cuts at, what the lanes like, how smooth are the roadways. Things like that, things that might impact whether or not you choose to say ride a bicycle on that street. And it's covered up. The LiDAR covered all of the neighborhoods I just showed on the previous map. We also, for some of the participants that we engaged in the surveys, we asked if they'd be willing to go the extra mile and wear a physical activity tracker on their wrist, which in this case was a Fitbit, and also carry around a air pollution microsensor. This particular one is called an air beam, and it's measuring PM2.5. It's small enough that you can just kind of clip it on a backpack and walk around with it. The Fitbits are compliance is an issue with the Fitbits. Getting participants to wear them all the times that they're being active can be challenging. And not just wear them, but remember to sync them with their phone. And then we have to do all these really complicated magic tricks to get the data from their phone to us. That part of the study has been really challenging, but we have just reams and reams of data from this that we're still in the process of processing here. Just to kind of, again, since we're in this project, we are still actively collecting data, so data collection hasn't stopped yet, but to just give you a sample of what some of this data looks like, here is a track of one of the participants over the course of, I think this is 4 days. So the orange here, just like where's this participant going? And then the size of these the size and color of these bubbles is what the PM2.5 levels are like as they're going around. And the first thing that pop out to you is like, what are those giant red bubbles? That's their home. And that's them cooking dinner a couple of different times inside of their home. So the biggest PM2.5 values by far were meal preparation. Another way of looking at this is that same participant. You know, there's lots of different ways of kind of pulling the data out. So on the upper left is the heart rate, their heart rate data. That's 1 hour averages. On the lower left is the number of steps that the Fitbit is recording, so you can kind of see when the participant's active, when they're not. One thing I noticed about this participant is they have a very different sleep schedule than I do, but they're very active in the middle of the night often. Also, on the upper right here is like how much air they're breathing per hour. And this is related to things about that individual, like how old they are, their sex, their race, and their height, most importantly, how tall they are. We use that information to kind of estimate how much air they're inhaling. And then on the lower right here, you put together the PM values that the microsensor is measuring with the amount of air that they're inhaling. Put those two things together, and you get the dose of PM2.5 per hour. And for this particular participant, over half of their dose occurred in a single hour. And that single hour was at home, and they were cooking. Or they were most likely cooking, based on everything else we know about the data from the PM2.5. Who knows, maybe they were burning something in the fireplace, but very unlikely in one box. So anyway, this is just a quick snapshot of what this data looks like. I wanted to come back. I put some acknowledgements here, and I want to come back to these in a second. But one thing I did want to do while we're kind of wrapping up, how much time do we have? So it's 1 o'clock now. 10 minutes for questions. 15 minutes. Okay, so I'll take like a couple of seconds here to say, well, what do we do about this? We have a big problem. It might seem insurmountable. What are some of the things we can do about it? And I know that this is an issue that is really addressed by urban planners and departments of transportation at city, state, and state, federal level. But I think in order to get momentum behind making an actual change to the way we live our lives every single day, requires a shift in cultural attitudes. And so I use as an example of this, when I'm teaching on this subject, I use as an example here. We used to have this huge public health crisis around smoking. We still do have a huge public health crisis around smoking, but it's not nearly as huge as it used to be. And one of the issues around it is that it used to just be a normal thing that people did. The smoking rates in the United States are astronomical, especially for males. Like the majority of the population smoked every single day, multiple times. And in order to get a shift in that, we had to change whether or not that's a culturally acceptable practice. It seemed normal because we'd always done it. And you grew up your whole life seeing it. It felt normal, but it's not. Doesn't mean it's required. I mean, it doesn't mean we can't change. The other thing that we have to really address is that it's just a fact of human behavior that nobody wants to ever lose anything. So if we propose any kind of even modest change to the way that you live your life, if you perceive that as being a reduction in your living standards, or that you're actually losing something, you automatically reject it. And I say that in general because that is a general
trait of human behavior. So we have to sort of somehow address these and many other important behavioral attributes of humans. I also want to point out is that if our population in Atlanta is growing, right? And we have a roadway network that really can't, you're gonna put an 18th and 19th and 20th lane on 17 lane downtown connector through Midtown. You really can't do that. You can't increase roadway capacity to any appreciable extent throughout most of town. But if you put 3 million more people on there, you better think that's not 3 million more cars on those roadways, or else it just makes everything more crowded for everybody to come out. I don't want to stop my discussion with just saying this, that really the solution to this, from any of the different ways that we might try to slice and dice this problem and look at it, the solution is that we have to make it easy to get around without a motor vehicle. You have to make it, the phrase I like to use is, you have to make it safe, pleasant, and convenient to go from point A to point B without getting in a car and driving there. Some fraction of the population, of course, probably a very large fraction of the population, will always be using a car to do that around Atlanta. But if you can say up those numbers to say 25% of the population can go from here to there without driving in a car, that will make things much better for the other 75% of the population. I'm a booster for MARTA as often as I can, because I do people say that it feels like there's a perception that it's unsafe, like it's way safer than driving down the roadway. If you want to talk about things that actually benefit your health, walking or doing something active like riding a bicycle will improve your health, whereas all the other, sitting in a car will actually make your health worse. And there's lots of approaches for trying to accomplish this, and most of them are related to changes in policy that make it easy to walk from one place to another. Okay, so I'm going to stop. I'm going to actually want to pause this screen here on my acknowledgements page and stop and take a second to answer any questions that the audience may have. Who would like to start us off? One back.
Okay, so I'm a little clear on the study on like barriers on the highway vegetation versus the sheet metal, what was kind of the conclusion, and which was most effective, kind of hybrid model, or
what was most effective was the more vegetation you have, the more effective it is. Now the hybrid model, but also is effective, like because it does have the vegetation there, but in the number of sample sites that we had, the fully vegetated ones were the ones that were most effective.
okay, was there anything else to accommodate for the loss in like noise control with the vegetation? Like, is there a way to kind of
So you're referring to like my statement that just the tree is not going to stop noise as well as the wall will. Well, the effect of the barrier on noise was not the focus of that study, so we weren't really analyzing that. But having both the solid barrier and the tree would affect both of those things. The solid barrier would be effective at noise abatement, and the tree would have. But I mean, we can really kind of get lost in details here. But if you just imagine you have a tree, or a line of trees, and then behind it you have a solid barrier. And you have airflow. So you have a difference in pressure from different sides. You're going to have air flowing through here. If you have that solid barrier here, then that prevents a constraint from the airflow. So the airflow would go up and over. It could go up and over the trees as well, and not actually go through the trees. Or if you don't have the barrier, the airflow more likely goes through the trees, so it kind of acts more like a filter.
Have you given any thought to or looked at micromobility and how that really impacts? I'm interested in that because I suspect your injury rate is significantly higher. But it's not the same as walking, but it is moderate physical activity. And it just looks like, in terms of trend, we're headed for a lot more micromobility.
That's a great question. That last study that I was referring to is the awardee is the micromobility group at AGSC, which I'm a member. Dr. Faley is the PI of that study and leader of that group. She's in the Urban Studies Institute here at GSU. We designed that study with micromobility in mind. But what we did not do is that we did not try to specifically direct the human subjects to use micromobility. If they already use micromobility, that's great. We'll have a chance to assess what that impact is. And there's a reason why. If you ask somebody to do something different, that is an intervention, which means you're doing a clinical trial now, which makes things way more complicated within the time frame that study was funded for. So we were not changing anyone's behavior. We're not asking them to change their behavior. Some of the participants did use micromobility. That's apparent when you can actually see someone moving in, you can see the GPS tracking places where there's not a roadway, but they're moving faster than a person can walk. That's the reason we know it's something about micromobility. To address the issue about like injury rates, I have not been firsthand involved in collecting that data, but looking at the papers that have been published about injury rates related to different types of micromobility, it is true that there are you do see, sort of telltale injuries associated with them. For example, you're way more likely to injure your wrists riding a scooter. That's the reason you show up in the emergency department. It's because you fell off and put your arms up to block. Also, the scooters, have a wheel this big around. So if you just imagine a hole in the sidewalk that's this big around, you're way more likely to fall into it than on a bicycle with a wheel this big around. So there are reasons that that could impact injury rates, and also reasons why the infrastructure could make that risk of injury either better or worse. But I'll just close off by saying I'm a big fan of micromobility. I think that is really is will have a positive effect on public health.
So you started off with some numbers about the extent of mortality that's due to highway crashes. And then you start, most of your time talking about air pollution.
Correct.
I'm wondering if you have any data that can compare the levels of mortality and morbidity from air pollution, especially transit connected air pollution, to the sort of crash numbers that you gave us.
So for a long time, up till like the mid 2010s, really mid to late 2010s, whenever I would talk about this subject, the thing I would always say is that the number of people that die because they breathe the emissions of a car is actually higher than the number of people that die because the car crashed. Now, since the mid to late 2010s, that's actually not true anymore. So that talking point can't be used, but the number is now smaller, which is a good thing if the public health win. But it's still a high number, and it's still a number that we, like all of these preventable deaths, you want the number to be 0, right? And the number is in the thousands. So if we say that 40,000 plus or minus people are dying in crashes from vehicles, the number that are dying that is attributable to the emissions is in the 10 to 15,000 range in today. Same ballpark, but smaller.
I have a question about the cooking pollution.
Okay.
So you mentioned frying oil and how it's not toxic, but it got me thinking about this debate that was in the news a couple months ago about gas stoves and.
Oh, that's a different type of pollution.
Yeah, but I was just wondering if you could talk about what kind of pollution you're talking
Okay.
about, and I don't know if we should, ever since that, I try to remember to open my window, for example.
Okay, yeah, I mean, that's a great question, and I'm really glad you asked that, because that is really important. So all of those little micro sensors that we're using now and giving people in all these different studies, those are all PM sensors. It's because it's much easier to measure a particle in the air than it is to measure a gas in the air on a small battery powered micro device. So all of those studies, none of them are measuring a gas-based pollutant. Okay, so when you're worried about using a natural gas stove with a pollutant, that is a big deal in that case, is a gas-based pollutant. It's nitrogen dioxide. When you're burning a high temperature flame, that blue flame on a gas stove is very high temperature. It's oxidizing the nitrogen that's already present in the air, and it's creating an indoor source of nitrogen dioxide. If you're in an unventilated space, it can accumulate very, very rapidly. Now, we do have nitrogen dioxide sensors in my lab that we use on many studies, including the daycare setting, but it's big, it's a tabletop instrument. And we've done those studies where we've taken it into kitchens, including kitchens at home, kitchens at daycares, and when the stove gets turned on, you see within a matter of minutes, the nitrogen dioxide levels go way, way up. This is a very harmful toxic pollutant in the ambient space. We know it's strongly associated with incidence and severity of asthma. That's just the tip of the iceberg as well. There are many other health outcomes are related to that exposure. So if you're in your kitchen and those numbers are in the hundreds, which like we've seen them do, that's really a big problem. The PM that's coming off of things like frying or baking also produces tons of particles as well. They're not, we don't consider them to be the same kind of toxic threat. It is possible if you were to burn something on the stove and you produce a lot of char in the air, that can be toxic, but a small droplet of olive oil that you would eat with having no problem whatsoever, that is absorbed through your airway epithelium in not the same way it is in your gastrointestinal tract, but still it's not going to end up having this super strong toxic effect systemically. That's why I say that those high levels aren't as concerning. Yes.
In the remote areas that you studied, were the levels of exposure to like toxins, an amount that would be like negative on the inhabitants of the area?
In some of those cases, those studies were not, the motivation was not to see what the exposure was like in the human population. So for example, going to the top of Greenwald, well, people don't live at the top. So we're not really concerned with that. What we did want to see is how does that affect the stability of the ice sheet there. Now, some of those other pictures I had were in these big mountain valleys. One of them was like these big snowy mountain valleys in the French Alps. In these valleys, to go from, just look at a map, to go between France and Italy, you got to go through the Alps, and you're constrained by these really steep-sided mountain valleys. And so most of the road traffic is through the valley floor, and then it goes to a tunnel. The valley comes out on the other side. So you have a lot of diesel trucks driving through the middle of these valleys. But in a really steep-sided mountain valley, you're constrained in the horizontal dirt. Like if you're out in Kansas and there's no, you don't have these walls. Like the wind can blow and it goes forever. But when you're in a valley like that, the walls of the mountains constrain the dispersion of the pollutants. So in other words, the pollutant concentrations can be much higher in that valley floor. Even though you're in a kind of a small town in the middle of nowhere up in the Alps, the fact that you have this major highway with tons of diesel trucks going through it can make the exposure of the place pretty high. Yes.
Are there any numbers comparing like the exposure to harmful pollutants you're in your vehicle in traffic compared to your like pedestrian walking alongside?
Yeah, that's also a great question. So one thing that's different about, say, driving a car on the downtown connector through here is that people don't walk along the downtown connector. That's by design, by law. You could say whether, hey, maybe we should have a place to walk through the middle of Midtown, but we don't. So there's not a whole lot of pedestrians right there. Now, there might be pedestrians on the streets just adjacent to that, but they're not right on that road. So if you're a block away, you're 2 blocks away, you do start to see the concentrations come down again. One thing we did do on that study is we were comparing the measurements inside the vehicle to the roadside monitoring station. So there are several around the city of Atlanta. On Georgia Tech's campus, some of you are Georgia Tech, there is a spot right there by where the 5th Street Bridge goes across I-75, 85, where the Georgia Environmental Protection Division has an air quality monitoring station there. By comparing what's inside the cabin of the vehicle to that spot, it is higher inside the car. That's because you're closer. I mean, you might think that, from here, 50 feet away to the edge of the road is a small distance, but it does matter in this case. You're right, you're the car right in front of you, that emission going straight into your vehicle as you go on.
You haven't mentioned electrification at all.
Okay, great question. Electrification. So what's electrification going to do? It's going to put those engine emissions to basically zero. more or less. Now you still have electricity generation emissions, but tends to be far away. And also we're getting a lot better at that. So we're reducing emissions associated with that. If you were to compare, class to class, the same type of vehicle that's internal combustion engine, it's the same type of vehicle that's an electric motor. The electric one tends to weigh about 1,000 to 2,000 pounds more because the batteries are very, very heavy. Because it weighs more, that means it's producing more tire wear. And when it stops hard, it uses its brake pads to stop, it's going to be releasing more brake pad particles. Now, if it's using regenerative braking when it stops, it's not releasing brake pad particles, but a sudden stop, like stopping the traffic, you're going to be releasing a lot of brake pad particles. So it is going to produce more of those emissions. And of course, they do nothing for all the traumatic. In fact, I should say nothing. A heavier vehicle results in more traumatic injuries. So, like all those other numbers are actually worse by having heavier vehicles. Yeah.
So, you asked us, what can we do?
Yeah.
You said, what can Atlanta do?
Like,
And there's technological change, which you just spoke about. There's reducing or changing transit modes, move more people from cars into other ways of traveling around.
yes, thank you.
And then there's urban form, just reducing how much we travel. And I was struck by your numbers between France and the United States. The difference in mortality was how much we travel.
Exactly.
We travel, I think your number, we travel 2.5 times as much per person. And that's what was killing us more than deaths per mile traveled. So it's changed transit modal split, and it's changed urban form. And I just want to say, I think globally we're making a lot of progress changing transit modal split. You had a slide from Amsterdam, and there's lots of slides, pictures of Amsterdam in the 1970s getting thrown around now. It used to look a lot like Atlanta, and in terms of traffic anyway. And the Paris example in the last 4 years has been transformative, this whole notion of a 15-minute city. And you can find plenty of examples in the US where we have very much improved complete street context. We've done a lot of that in Atlanta. Our walk score has gone up a bit in the last few years. But on urban form, Atlanta is not doing anything near what it could or should be doing or needs to do to address your concern. And the United States is not doing what it needs to. And transit modal split, technological change will not get you there if distances that people need to travel are not such that they will support mass transit.
Yeah, I agree. Everything you said is exactly right. We have to make these changes, or we're going to be dealing with the same problems in the future. I'm really about that. I will say I'm really encouraged that we are at least talking about upzoning all around the United States. It is a topic of conversation. The housing affordability crisis, as terrible as it is, at least got us talking about the fact that the way we are building housing has a negative impact on our country. And hopefully that means that we will change how we do that in the future. Maybe not, but I'm hopeful.
Is that just directly related to density, that higher density really is better for public health because you really don't need to drive as much, it's just more walkable opportunities, more destinations?
That is one of the main ways, but there are really 5 to 10 ways that increasing density in urban areas has very positive public health impacts.
Yeah.
But increasing walkability is near the top of the list.
All right, well, if there aren't any final questions, just remains to thank our speakers.
Thank you.